In progress.
Good morning. My name is Nadia Hamid. I'm a GYN pathologist at MD Anderson Cancer Center. Today, I will be talking about the diagnostic challenges of emerging and common high-grade endometrial carcinoma, and then their impact on treatment and clinical outcome. As you may know, endometrial carcinoma has different histotypes. The most common one is the low-grade endometrioid adenocarcinoma, including FIGO grade 1 and 2. And then the other carcinoma, the high-grade clear cell, uterine serous, triple MT, mucinous neuroendocrine, etc. I will start my presentation with case number 1. 74-year-old female with postmenopausal bleeding. During physical exam, they found a mass involving cervix and endometria. And by imaging, there were multiple pulmonary nodules and enlarged hilar lymph nodes. This is the endometrial biopsy. As you see over here, we don't have a pointer? Where? So from low power, we can see we have a solid sheet of neoplastic cells. And if we go more high power, we can see the neoplastic cells are very cohesive with a prominent nucleoli and necrosis. There are areas that we can appreciate over here, the squamous abrupt organization. And then if we go in another area, we can see the necrosis, and also we can see what we call it the shadow cells, the ghost cells. IHC, the tumor is positive for pankeratin, synaptophysin, CDX2, while negative for the GYN markers like PAX8. Other IHC, it was negative for ER, PR, and then for other neuroendocrine markers, it was negative for chromogranin, and because of the squamous keratinization, it was negative. We did the P40, was negative for P40. And then because the mass is involving the cervix and it has some squamous keratinization, we did the high-risk HPV, which was negative. And then this is the other stain that we did. This is the beta-catenin. The beta-catenin showed a nuclear localization. In addition to that, we have cytoplasmic staining. So the final diagnosis is pilometrics, like high-grade endometrial carcinoma. And the patient presented, as I mentioned earlier, with a stage 4 disease with lung mets. So this entity is a recent entity. The first case report describing those histologic features was back in 1996 when they described an ovarian carcinoma that has low-grade endometrioid, the glandular component, and also it showed some squamous differentiation and positivity for synaptophysin, indicating there is neuroendocrine differentiation. After that, it was followed by few case reports, mainly ovarian tumors. Until 2022, Weissman described 5 cases of endometrioid adenocarcinoma with high-grade divergent differentiation resembling the cutaneous pilometrics carcinoma. So the main thing over here, the histologic features, nested pattern, geographic necrosis, and squamous differentiation with ghost cells. The tricky thing about this entity that the GYN markers are all negative, PAX8, ER, PR, and the most confusing thing is the presence of neuroendocrine differentiation and also CDX2. In terms of molecular, those cases showed CTNNB1 mutation on exon 3. Those cases usually have poor outcome. So the buzzwords for this entity is geographic necrosis, basaloid cells, and ghost cells, as we see over here. And then Weissman expanded his series into 13 cases. 6 of them were MMR proficient, and 7 of them were MMR deficient. 62% of the patients presented with high stage, advanced stage, and 77% of them died of disease within 24 months. And only 5 cases were tested by doing the NGS testing, and all of them showed CT and B1 mutation. So the differential diagnosis for this entity is FIGO grade 3 endometrioid adenocarcinoma, large cell neuroendocrine carcinoma, and undiff carcinoma, as well as squamous cell carcinoma. So the FIGO grade 3 endometrioid adenocarcinoma kind of similar in terms of forming solid areas as we see over here. But then in this case, you have the GYN markers, which is PAX8 and ER. That we don't see in the pilometrics entity. And again, here we don't see ghost cells. We can see some squamous metaplasia. And also in FIGO grade 3 endometrioid adenocarcinoma, neuroendocrine markers are negative. The other differential diagnosis is the large cell neuroendocrine carcinoma. It's also forming, nested pattern. Also, we can see some geographic necrosis. And also, usually large cell neuroendocrine carcinoma, we have some prominent keratinization sometimes, but ghost cells are not present. Also, neuroendocrine carcinoma, as you know, we have positivity for synaptophysin chromogranin, which kind of similar to the pilometrics. Then the undiff. The undiff also forms solid nest like the pilometrics. However, here the cells are discohesive, not cohesive like in pilometrics. Also, the other similarity, the presence of synaptophysin positivity, sometimes it's patchy. But here we have the pankeratin is negative. Why here is negative or sometimes decrease in staining. While in pilometrics, you can have, diffuse staining for pankeratin. And also, we do usually this mark A4. So this mark A4 is lost in undiff, which confirm the diagnosis of undiff carcinoma. So take home message. Think about this entity when there is an abrupt keratinization and shadow cells. It can mimic other high-grade endometrial carcinoma, as I mentioned, like the neuroendocrine carcinoma and undiff carcinoma. Doing the beta-catenin will confirm this by the presence of nuclear localization and then also loss of Müllerian markers. MMR can help. If there is MMR loss, that indicate this is, endometrial carcinoma. And if you think, because of the squamous differentiation, this could be coming from the cervix, we can do the high-risk HPV, which is negative in this case. So for this case, for the follow-up, the patient received chemo, and then they did the interval THBSO and para-aortic lymphadenectomy. But after 6 months, she relapsed with 7-centimeter para-aortic lymph node, and she ended up in hospice care. Case number 2, 67-year-old female with endometrial mass, 4.5 centimeter. That was an outside case. The outside diagnosis was serous carcinoma. And then in the outside facility, they did the THBSO, omentectomy, and lymphadenectomy. And we received the case in MD Anderson as a second opinion. And as you see, bring my back. So this is the hysterectomy specimen. As you see, the tumor is involving the entire thickness of the myometrium, forming glandular structures with necrosis. This is a high power as we see, we have the tumor-forming glands. We have the nuclei shows high-grade cytology. And then in these areas, we can see there is a clear cytoplasm. So whenever we see clear cytoplasm, we always think about a clear cell carcinoma. Anyway, whenever you think about clear cell carcinoma, think about another entity that I will discuss shortly. So the IHC here, we did the GYN markers, ERPR, both did negative. And because of the possibility one of the differential diagnoses is a clear cell carcinoma, we did the napsin A. Napsin A was negative. We have P16 diffusely positive, and P53 is aberrant, null pattern. So with these IHC, the outside diagnosis was uterine serous carcinoma. As you know, in uterine serous, it's a high grade. We usually have aberrant P53 and P16, and this is a pitfall. So at MD Anderson, we did additional stains because, as I said, whenever we see clear cytoplasm, high-grade cytologic features, then we need to think about this entity. So SAL4 is diffusely positive, Villen is positive, and CDX2. So based on these IHC and the morphology, the diagnosis is yolk sac tumor. So this patient received, because of the diagnosis of uterine serous, she received carbotaxol, but she died of disease after 6 months. The tumor, the course of the disease was really aggressive. So what is the yolk sac tumor of the endometrium? Usually we know that the yolk sac tumor is a germ cell tumor. We see it mainly in the ovary, but we can see it in the endometrium, but very rare as a pure germ cell tumor. In postmenopausal women, we can see it as a part of carcinoma. In addition to carcinoma, carcinosarcoma, we call it somatically derived yolk sac. The features, the histologic features is similar to the ovarian germ cell tumor, the yolk sac, but sometimes it show like more of the glandular, as I showed you in the picture, with a clear cytoplasm. And these are the IHC that we usually confirm our diagnosis. It's positive for pankeratin, alpha-fetoprotein. And by the way, alpha-fetoprotein in those somatically derived usually is not elevated when they do the blood test. The glycan-3, and then our screening IHC is SAL4, and usually because it's a germ cell, PAX8 is negative, and you can have aberrant P53, whether it's null pattern or nuclear overexpression. So whenever you have clear cytoplasm, high-grade nuclear features, negative GYN markers like PAX8, ERPR, CK7, napsin A, think about yolk sac tumor. The main differential diagnosis for this entity is serous carcinoma and a clear cell carcinoma. In serous carcinoma and clear cell, both are high-grade cytology. Both can show aberrant P53 and diffuse P16. Clear cell carcinoma markers, HNF1 beta, napsin A, and MOCAR. In clear cell carcinoma, usually we have negative ER-PR, but in serous carcinoma, usually you have variable ER and PR. So take-home message, yolk sac tumor can mimic high-grade endometrial carcinoma like clear cell, like serous carcinoma. As I mentioned, high-grade cytology, clear cytoplasm, and it can have aberrant P53 with diffuse P16, make it, mimicking the other entities, and it will be a pitfall to diagnose it as a uterine serous. So, and also negativity for ER, PR. CK7 is a very helpful tool, and then you can start with SAL4 to exclude this possibility. This is my medical college in Baghdad. I'm originally from Baghdad, Iraq. Thank you. Any questions?
Thank you so much. Actually, that was a very interesting presentation. I just wanted to ask you, the presentation was very granular. Like, if somebody is literally looking at a case, on a rainy day, it's very granular. And so what can you suggest to keep that in mind? Because that's a very rare presentation.
Yeah.
Number two, what can we look for to make sure that we're not just calling it fiber grade one and two carcinoma as this case was done?
So first of all, the morphology, as I mentioned. So nuclear features. The nuclear features are very, ugly for a fiber 1 or fiber 2. That's number one. Then the cytoplasmic eclating. For every, that's what I recommend. For every endometrial carcinoma, it's really good to do the hormonal receptors, ERPR, and then P53, P16. I don't know if you do here the MMR proteins, MLH1, PMS2.
We
Okay, because these are very important. So we do this for every single endometrial, whether biopsy, resection. We have to have those information even before doing the hysterectomy. The clinician, the GYN onc would like to have those information, ER, PR, P53, P16. We do it whenever we think this is a high grade like cytology, just to be along with the P53. Because if you have aberrant P53, you should have diffuse block like P16. So that's the thing. If you do ERPR and you have ERPR negative, then this is not endometrioid. Even serous, you should have some ERPR. You can do CK7 when you have a clear cytoplasm. I start with the CK7 also on PAX8. PAX8 should be positive in endometrial carcinoma. Yeah. So if you do the simple panel, ERPR, P53, and you see ERPR negative, if you see P53 aberrant, then you're not dealing with a low-grade endometrioid.
Makes sense. Thanks so much. That's very nice. But do you regularly do ERPR on biopsies?
Yes. I do everything, even the MMR, even the MMR. And now with poly mutation, if I have atypia, and I don't have a burnt P53, we do the NGS because the prognosis is super important.
Thank you so much. That was one of these very eye-opening and very good. Thank you so much.
Sure. Mhm. No, it's not associated with. We call it pilometric slide because it has the features of pilometric slide. It has those shadow cells. To call it pilometrics, you have to have the shadow cells because you can have fibrograde 3 solid component with geographic necrosis. But once you have the squamous abrupt keratinization and mainly the shadow cells, then that's why they call it pilometric slide. They found that these cases have really poor prognosis. One of the cases that I had, the patient passed away after 6 months. And the classical presentation, mass involving endometrium cervix with multiple lung nodules. Uh-huh. Well, there is, yes. So there is a case report. It started with ovarian carcinoma pilometric slide with met to the skin. There is a case report. Yeah, it can happen. Yeah, not the opposite. I haven't seen the opposite from the skin because usually the pilometrics of the skin is kind of almost confined, well-formed nodule. Once you start to have desmoplastic and invasion, this is most likely not the primary because the one in the skin after the excision, it has, a benign course. Yes, better outcome. No, I don't do that. I usually do it. So I use beta-catenin in 2 cases. If I have a typical hyperplasia that I'm not sure, in biopsy, sometimes you have a crowding, you can sometimes have simple hyperplasia. So I do the beta-catenin. If I have a nuclear localization, I will feel more comfortable along with P10 and PAX2 to call it atypical hyperplasia. And then I use it for the pilometrics. I don't use it for the other endometrial carcinoma.
2 or a 1A or P10 complementary or
in case of atypical hyperplasia. So in atypical hyperplasia, as you know, in the WHO book, it says it's different from the past, classification was complex atypical hyperplasia, simple atypical hyperplasia. Now we have only atypical hyperplasia. The terminology of simple and complex, we don't use it anymore. So the definition is to compare, the area of glandular crowding with the background. So if you see cytologic difference, not atypia, if your areas of glandular crowding is different from the background in terms of cytology, the glands are more complex in terms of architecture, then this is atypical. So sometimes when I get the biopsy, I don't have the background to compare. So I'm not sure. So in this case, I use the panel PAX2, P10, and beta-catenin. So if I have lost PAX2, P10, and nuclear localization of beta-catenin, then that's a confirmation I'm dealing with atypical hyperplasia.
Thank you.
You're welcome.
Can we just like present a certificate for you? Just thank you so much. This was I can just come
Here? Oh.
step out here. Yeah.
Can I give you back this?
Yeah, thanks. Appreciate it. Thank you so much for the presentation. It was an excellent. Thanks. Yes. Thank you.
The next topic for presentation is digital pathology 360-degree scanners, standards, software, and strategy versus PACS. Where do we stand? This will be presented by Dr. Ibrahim Mansoor. I would like to call Sir on stage to deliver his presentation.
Good morning, everyone. And I have a slightly different way of presenting things. I'm kind of more digital guy, so I'm going to be presenting digital aspects of the pathology. So, thank you so much for the introduction, Dr. Kwarna. How do you it on like this? Okay, so good morning, everyone. My name is Dr. Ibrahim. I'm actually chairman of the laboratory services at King's College Hospital, London, Jeddah. And I have a special interest in clinical informatics, digital pathology, and artificial intelligence. So to reach to artificial intelligence, you need to first digitize. So that's why we will talk about how to digitize your slides and your specimens so you can actually ultimately ripe the fruit of these digitized specimens and come and utilize AI solutions. So we are, since 2015, have entered a new revolution. We started from industrial revolution. We started machines, people start moving to industries, cities start to form, and then we move to mass production. Then we move to automation. Since 2015, we have entered a new phase of revolution, which is called the age of connectivity. And it is because of one thing that happened in 2015, and that is cloud. Cloud is computing and storage and anything you can think around computing as a utility. Right now, if you need to do computing, you need to have a laptop or a PC or a system that you can log in and work. With the availability of cloud services, you can actually log into any machine and you can access the highest speed computing, any storage that you need, and as an instant. And that revolutionized the age. And that's the age of connectivity that we are entering in. It's a huge industry. It has so many things attached to it. Digitalization is one of them. Digital pathology is one of them. IoTs, Internet of Things, the wearables, sensors all over the hospitals and industries. that are constantly transmitting data, and they are stored and converted into a very meaningful data. So you need to understand that we have recently entered into this age, and it has revolutionized at a pace that we cannot even imagine. To make you understand this, this is a McKinsey, one of the largest, one of the main organization that actually does surveys, data collections, and everything. They interviewed approximately 73 CEOs, and they asked them many, many questions, and they asked what is the most highly impactful areas that is going to affect the coming 3 to 5 years. And this is done as 2023, just 1.5 years ago. One of the largest point of concern was this rise of disruptive digital technology, especially in healthcare. Artificial intelligence and this disruptive technology, it's going to have a huge influence on the way we practice medicine. So this is just to give you an impact. What is the impact of this technology and how it is moving forward? So I really recommend that, a lot of us are old school. Sometimes we hesitate. This is the time to change. So my presentation is going to be just a brief layout of my presentation is going to be why digital pathology. To go digital pathology, you need to build the plumbing. The plumbing is the IT infrastructure that's going to be using the huge databases that you're creating. And then we'll talk about the file formats, and we will talk about DICOM. DICOM is one of the revolutionary file formats that is changing digital pathology, the way digital pathology works. And then we'll a little bit talk about what are the scanners, what we're looking for in the scanners, and then the workflows, and then how to prepare yourself for, as an institution, for an AI, and then you lock the roadmap for the future. Okay, so digital pathology, currently, when I say digital pathology, I really mean workflows implemented on digital pathology. It's not like you have a scanner sitting there, and once in a while for teaching students, tumor board cases, rarely you start using those scanners. That's not a utilization of a digital pathology. That's literally not a digital pathology. It's just a scanner sitting there, and you once in a while use it. That does not mean you're using digital pathology. What I mean by digital pathology is using digital pathology for primary diagnosis. You take the glass slides, you throw it out. What you're working on, just like a radiologist, on the screens. That's really what is digital pathology. So currently, if you look at how many hospitals have implemented primary diagnosis level of digital pathology, less than 10%. That includes United States, that includes Europe, Middle East, and Far East, not that many. China is improving really fast. Europe is improving fast. America is less than 5%. So overall, globally, less than 10%. Although, how many scanners and how many facilities do we have? So this is something that it requires a change, and that change is very painful. So that is why I'm presenting this idea and this concept. So when we talk about digital pathology, it's not about just buying scanners. There are 4 areas. And this is one of the reasons why people buy scanners and they completely fail, because they don't plan correctly. When you buy digital pathology, when you look for the scanner, before scanner, you need to make sure, number 1, scanners, hardwares, IT, what pipeline plumbing you have, what kind of plumbing you're going to use, what infrastructure do you have, IT support is available or not, do you have the workflows, are you able, are your colleague teams are competent, willing to take the risk, throwing the glass slide away and start signing out cases on the screen, are they comfortable with it? And then incorporate the pupil. Okay, so the 3 big takeaways, if you can just take out these 3 points from my presentation, please aim for primary diagnosis. It's not that difficult. It requires a lot of work, but it's not that difficult. Number 2, before you install the scanners, work on your plumbing. It should be the same plumbing that the rest of the hospital uses. There is a lot of plumbing already installed in the hospital. Radiology is already using it. You do not want to come in and create your own plumbing system. You need to be integrated into the same that CT scan and MRI are working on. You need to be part of the same plumbing, same IT infrastructure. So that's most important thing. And that includes DICOM. DICOM is a format that is compatible to work with a hospital infrastructure, not a lab infrastructure. So that's why DICOMs are very important. And number three, really operationalize AI. With mentioning of AI, I'm just going to briefly talk about what is AI. So AI is basically a data cruncher. You throw any data, any voice, image, just you name it, you throw into it, it's going to just somehow find patterns in it to a level that a human being cannot even imagine. A human being cannot even imagine. So just give you an example. I was a fellow at Yale University. This was in 2006. And we had a very difficult query. We thought that in cytology, it's very difficult to differentiate between follicular neoplasm and parathyroid adenoma. They look almost the same, microfollicles, small, same nuclei, no difference at all. Some pathologists believe that they can tell apart, morphology only. Others say we cannot. I happened to look at, and I found 20 cases of parathyroid adenomas, cytology material. And then follicular adenomas, there are many, many. So I trained on 5 cases only, 2,000 cells. Follicular adenoma, parathyroid adenoma. I annotated the slides and I differentiated them. It was a binary classification. You need to understand these terminologies. When you talk AI, you need to understand what is binary classification, parathyroid, follicular. The AI only is differentiating. What is the difference between two classifications? Malignant, benign. You know, these are classifications that you train the model on. So my model was very basic. Binary classification, simplest of the simplest. What was the sensitivity specificity? 100%. Sensitivity 100%, specificity 100%, positive predictive value 100%, negative predictive value 100%. 100%. Human eye cannot tell. But only on 2,000 cells of 5 cases, I was able to tell them apart. This is the power of AI. And you can work on AI on simple things. Very simple things. We think of AI as something that's going to take over the world, isn't it? No, that's not AI. AI is small. When you want to use AI, you need to use small things. And you master them. Few classifications. Not taking over the entire world. No, few classifications. Okay? So how does AI looks at the images, the pathology images? You know the X-rays? The radiologists are already using AI. They're lucky in the sense that their data size is very small. Their X-ray grid is 2 grids. And it's black and white. It's either gray or white, isn't it? It's black or white and something in between. So what it does is it creates a grid, a huge grid. And every pixel is dated by a number, depending on the intensity of the grayness or blackness. Okay? In digital pathology and their data, a CT scan can reach up to 50 megabytes. They're not reaching gigabytes. 1 gigabyte max. A high resolution MRI can reach 3-4 gigabytes. Histopathology, the problem is it is colored. And colored means we have RGB, red, green, blue. They combine together to create colors. So that's why in digital pathology, we have 3 grids, red, green, and blue. So the amount of data is immense. So when you throw this data, the computer AI is data hungry. So that's why it really loves the digital pathology, because it's really able to find beautiful patterns out of this rich data. Okay? So the conventional computing, when we do conventional computing, we have data, we define the rules, and computing follows the rules and gives you an outcome. It could be a very complex model, predictive model, statistical model. What it does is it follows a rule set and it filters the data through that rule set and gives you an outcome. AI is different. AI is different. We give data, but we do not give the rules. We give the output as well, and that output is called ground truth. You know, I'm the one who trained the model. This is parathyroid. This is thyroid. This is parathyroid. This is the output, isn't it? I'm training the model on a ground truth. And then we throw the data, and the computer figures out the rules. So basically, the difference between regular computing versus AI is AI figures out the rules from the input-output data that you train them on. Okay. So with that, the power of AI in histopathology is that the data size is huge. You have almost 100 by 100,000 pixels, and you have 3 grids RGB. It can reach almost 1 billion pixels combined together. So if you trained multiple slides on a diagnosis as a ground truth, this is grade 1 breast cancer, this is grade 2 breast cancer, this is grade 3 breast cancer. The ground truth is diagnosis. You train 50 cases, the computer will predict the diagnosis perfectly. Beyond that, so this is our normal routine. This is what we do. We look at the morphology and we predict the diagnosis because we are trained in it. But beyond human perception, if you train that same breast cases on patient survival, you put the histology slide, this patient survived this many years, this patient survived this many years, this patient survived this many years. And you ask the model, unknown case, predict the survival. It will predict the survival. The ground truth does not have to be diagnosis. It could be patient survival. It could be ERPR HER2 mutation status. It can predict ERPR HER2 mutation status from H&E slide. It can predict protein expressions from the H&E slides, but you need to train him first. So you understand where I'm taking you. H&E slide is converting so much information that our human eyes cannot perceive. And you can predict a lot of information from just an H&E by training the models on the ground truth. So just imagine predictive diagnosis, patient survival, mutation status, subtypes that we don't even know, subtype categorizations, discovery of new type of cancers. We know that these are the certain types of breast cancer already exist. The computer will analyze and say, no, there's another category of cases that are slightly different from the rest of them. So we have a discovery type. We discover new morphological types, therapy and molecular pathways. You name it, you can predict. And the reason why? Because of the richness of the data. To reach to that data, you need to have digitization. Unless you have digitization, you cannot reach to that status of utilizing AI. So why do you want digital pathology? For the current level, there is a lot of benefit in digital pathology. You know, a glass slide is like a book. It is sitting somewhere in somebody's cabinet. If you want to reach it, you have to call that person. He's going to take the book. He's going to put it in the mail. He's going to ship it to you. You're going to get the book, and then you will read it. Digital pathology is like ebook, searchable, secure, with multiple copies. No smashing of slides. Somebody dropped the slide, book is gone. That book completely gone, disappeared. No more. If you digitize your slides, it's never going to disappear. There are multiple copies sitting in multiple servers. Instantly searchable, secure, and accessible. You can instantly send the link to another person. He can read the book immediately. So you understand? Remote access, safety, security, anything that you can think of that is coming through digital pathology. Collaboration, tumor board meetings, students, pathologist interactions, many ways of. The biggest benefit that I think that is needed is the AI integration. And there are many solutions already available in the market. It's not that difficult. AI integration is the goal. And then the last thing, archiving. Glass slides, 20 years old, if you want to reach it, how difficult it is to get the slide that is 20 years old. In digitized slides, less than 3 hours, you're able to get it. And I'm going to show you how it happens. So please understand, digitization is not just about scanners. It's a multidisciplinary transformation of the entire hospital. Every party is involved. It includes hardwares, that includes scanners, it includes monitors, 4K monitors that are calibrated, just like radiology. They're not random PCs. No, they are specifically designed monitors that are 4K and they're calibrated. You need IT infrastructure, networks, storage, archiving. You need to design workflows, integration with LIS, and automation. You need people and governance to be together, okay? And the training and model. Now, one of the things that you need to, the IT, when I say plumbing, what is that plumbing? Bandwidth. Bandwidth is like when you are using plumbing, it's the width of the pipe. When you're using plumbing, I'm using an example of plumbing as an example. When you're using instead of water, we're using information is flowing through the pipes of the IT infrastructure. Bandwidth is the width of the pipe. How wide is the pipe? And latency is how available the space is. You have a pipe, but it's already full, and you want to push the information through. It's not going to go. It's already full. So that's the latency. And latency is affected by so many factors. It's affected by the Wi-Fi connection, the routers, there are switches. There's hundreds of connections in between my scanner to reach to the main server or to the cloud. All of this is latency. Any one stop in between, one switch is old, not transmitting that much information, I'm going to block the entire thing. I have a big pipe, but one place I have this small pipe in between connection. What's the purpose of having the big pipe? The latency is gone because of this small connection. So latency involves every single connection points till the processing unit, okay? So you basically need to segment your network. You know, when you have traffic, in a lot of the big cities, when you have traffic, what do you do? They put the trucks in the last lane, isn't it? And our digital pathology slides are like trucks. They're huge. So you don't want to mix them with the traffic. You want to create a separate lane for them. That's called segmentation of your network. You create a separate pathways for the high level heavy trucks. And that's the slides, okay? And then you need to scale up. Every single connection you need to scale up so make it can handle things. Storage and archiving is very critical. You know, I'm telling you guys because you guys are pathologists. When you think of a scanner, you think of images only and digital scanners and slides. You do not think of these things. These are equally important things. Otherwise, you have a scanner that you bought 20 years ago and it's just sitting there. Nobody's going to use it. So you need to understand these concepts before you buy a scanner. Storage and archiving is the most expensive connections of digital pathology. Just like when you have a slide. Last week, tumor board, where is it sitting? On your desk. Few months back case, where is it sitting? In the main hospital storage, lab storage. 20 years old case, where is it sitting? In the warehouse. Very similarly, you have a very similar archiving of storage. You have hot cache memories. There are cases within 1 week. They're sitting very close to you. They're sitting in the RAM or in the storage device that is very close to your accessible. So you can easily go back. Warm cases are like 2 years old. They are accessible, but it takes a little bit more time. And then you have cold archives that are just for retention laws. You know, you have to have a slide for 10 years or 15 years. And then you can put them into tapes and things like that. It will take 4 or 5 hours to retrieve the case from there, okay? So you need to understand every single component of digital pathology is equally important. Security is also very important. It brings in new concept of security. When you have the file, and now you're transferring through this plumbing, the glass slide, I sit on it, I close my door, I lock the door on the lab, secure. Now this digital slide is going through the plumbing. So anybody can drill a hole and grab the slide. So you need to know the security of this issue. So you need to encrypt the flight, encrypt during the flight and rest. Any movement of the slide has to be encrypted. During the flight means movement, encrypted, and resting, encrypted. Adopt DICOM. And I'm going to come to DICOM. DICOM is an open system. You know, we have been working on digital pathology for a really long period of time. It was a startup. Everybody created their own proprietary patented file systems. Leica has its own, this one has its own, everybody has their own systems. But it locks them. You lock into a corner. The moment you go into an open system, it opens everybody from anywhere in the world, from India, from Pakistan, from US, from Malaysia. Lock and start working on it, creating new solutions, new ideas, new formats. Open systems are always good. ChatGPT versus DeepSeek. What do you think is going to survive? Well, right now, ChatGPT is very good, but DeepSeek is open. Anybody can download source code, do anything with it. What do you think is going to happen? Open is always better and easier, always flourishes. You put, instead of 500 staff working on ChatGPT, DeepSeek, half of the world is working on it. I know all the AI experts and engineers. They download the source code and they start playing with it. They start doing new things. Open is always good. Ensure the viewers that we're looking at, they are up to date. There's a newer web-based, it's called HTML5 or WebGL. They have to be up to date. So secure and the best possible manner. Now we come to the file formats. We already talked about, you know, there are proprietary file formats, SVS, NDPI. These are companies that are making it. But they're locked and you cannot access in other systems. You have to buy their own systems. DICOM is open healthcare standard and anybody can access this. The advice is choose openness from the earliest possible. If you're open from the very start, you will have the friendliness and easiness later on. Okay, these are the formats, and you can see the vendor lock-in. SVS is one of the file formats that is fast, but is vendor locked in. NDPI is also SVS is actually with the Leica, and NDPI is another one of the vendors, but it's limited. TIFF files are open source files, but they are very large, very difficult to work with. DICOM is open, metadata rich, and has a lot of ecosystem, is constantly maturing because it's an open system. So the key message is fast today. You're thinking of Leica and you're thinking of SVS. It's very fast. Of course, DICOM is maturing right now, has slight troubles. It's a journey. DICOM is not like you bring it and things works. It's a journey. So you think, okay, well, I want fast, just bring in the SVS format. But fast today, stuck tomorrow. And then don't spend your AI budget just converting files. You know, at the end of the day, when you were converting these files into a DICOM, it's going to take a lot of time and effort. So think of it. Think of future right now. Take the little pains and go for it. See, the non-DICOM formats, they fracture your ecosystem. They're not compatible with the radiology DICOM. They're not compatible with the cardiology DICOM systems. Almost everybody else has adopted DICOMs. We are the only one left behind, and we are going in the direction. So the conversion consumes a lot of effort. They completely lose the metadata. Metadata is very critical for AI. Stains, location, and all these kind of information that is stored within the DICOM information. And then the AI pipeline, it requires metadata in these things. So today, DICOM, one of the greatest thing of DICOM, because the files are large, 15 gigabyte, instead of retrieving the entire slide, you know, just like when you are watching Netflix or you're watching a YouTube, you don't download the entire YouTube and start watching. No, it only downloads like even if you're starting, it's going to download like the first 3 minutes. And the rest of them, you will see that it's gray and the rest is gray and that's green. If you move in the middle, it's going to work for a little bit and then download where you want to start. It does not download the entire thing first into your PC. It is called streaming. Similarly, when we are working in digital pathology, we do not want the entire slide to be downloaded. We only want the area that we are interested in. So what they did was they created tiles. And these tiles are streamed according to, just like in minutes in a video, they are tiles within the slide. So if you put your slide in the middle of the slide, so it activates that tile and downloads that tile and then starts slightly working on the surrounding tiles. So it is expecting that you're going to move right or left. That's called streaming. This is the power of DICOM. Smooth. As if the whole slide is right in front of your hands. So, and the way it works is it actually downloads every single scanning power. And you can move to the 40x and it will move to 40x. And then which tile you are on, it will go and start downloading that. Instead of downloading the entire thing, 20 giga, 30 giga, you just work on the things that you're working on. The DICOM, it's the future, but it's still maturing. It's a journey. It has a lot of benefits, but there's some challenges. You need to map the different things. You need to make sure the metadata is correct. The files are slightly larger than the other formats. So the performance can be a little bit slower, but that needs a little validation, tuning, and things like that. So what are you looking for you buying a scanner? So now, after such a long discussion, we are coming to scanner. We usually think a scanner is the ultimate thing. You look for what scanner you're going to buy. When you're looking at a scanner, a lot of people ask me, what should I look for in a scanner? Throughput. 40x throughput. What is the 40x throughput for the scanner? Auto load capacity. How many auto loaders can I load? And it will automatically start. Native DICOM. Very important. You don't want to convert an SVS file and then later convert it into DICOM. That takes a lot of effort and a lot of storage. You need integration with your Barco LIS. 2D reader, you create a work list. When you create the cases today in any LIS, when you have the LIS today, all the cases comes, it creates work list. The work list is sent to the scanner. The scanner links, the slide comes, it reads the case number, it links it to the work list, starts scanning. So no slide is just scanned orphan. It's just sitting there, nobody knows what case is this. No, you need work lists and you need integration with your LIS. This is a very critical point. It's an extremely critical point that a lot of people lack. One of the things, if you're using cytology, you need dynamic focus, Z-stacking,
And then you also want to have multimodality, not only light, fluorescence. If you're in future bringing fluorescence, you need to have in the same capacity to expand to the fluorescence. These are the things that I mentioned about the things that 40x speed slide per hour 40x, dynamic autofocusing, Z stacking, native DICOM, barcode LIS integration with HL7. The last thing I just didn't mention was compression. The way streaming works is through a new way of technology, which is called JPEG 2000, which actually helps compress the file. We can actually compress in, because these are so huge files, we can compress them 15:1 to 20:1 without any loss of, which is significant. But some of the latest technologies, the DICOM, they can compress it to 30:1, which is significant. But it does not affect the quality. It maintains the quality. So you need to understand that. This is another one of the greatest benefit of DICOM. A few other things that you need to look for when you're asking the vendors, from slide scan to first tile speed is usually less than 1 second within the VLAN. And if it's remote from home, if you're opening a slide, 5 to 6 seconds. That's something very critical you need to ask. Viewers compatibility. You want your slides to be open to anybody. Like if I send a slide to another hospital, I send a slide to Dr. And she wants to review it, she should be able to open on any viewer. It's completely open. Okay. Footprints, power, noise, things like that. Because lab is such a space limited space that you need to make sure that footprint is not that much. Security, and then the total cost of the product. Again, I mentioned flight to first flight is less than 2 seconds. If it's on your own land, if it's remote, 5 to 7 seconds. You need to test the system as if it's a Monday morning, maximum number of cases. When you are implementing a system, you need to train it, you need to test it, pilot it as if a Monday morning, 2 autoloaders completely scanning and making sure there is no failed scan. The failed scan rate should be less than 1%. You need to document that, you need to pilot it, you need to make sure that the failed scan rate is less than 1%. These are the things that you ask because when you go digital pathology, they're going to bring the pathologist up front, and now you are like, what should I do? These are the things that you want to ask, okay? Again, barcode is very critical. LIS integrated, it reads the 2D scanning, it links it to the work list. If there's no work list, no scanning. You do not want to create an orphan slides. Complete mess, disaster. Do not want to go in that direction. Completely integrate with LIS. DICOM interoperability, streaming through JPEG and JPIP, means tile-like streaming, and then Z stacking for cytology. So just the image below, you can see that in cytology, some of the areas, that's the image on this side, you can see some of the areas can be focused. So you need multiple levels of stacking here, just like here. You see, you need few levels of stacking to get to that. It's called Z stacking. Make sure when you are getting Z stacking, the file size should not exceed crazy. Sometimes they Z stack everything. You don't want to just Z stack. No, they need to be intelligent systems. Only on the area which is not focused, Z stack that area. So make sure that you're checking that. Again, these are tips. Test the peak workloads. Overnight batches, run it. Measure the slide to first time, and check your slowest link. Go home through access to the VPN and see if the slide is opening how. And then build a communication with your vendor and see what is the future plans, what AI platforms they're bringing in, what models can they link with other AI models and things like that. And pilot multiple brands before bringing in. Workflows are very critical. From accession to AI archiving, you need to understand each workflow and make sure that every step is being designed and integrated. The pain points, that usually when people are bringing pain points, the strongest pain point is scanning a slide with no ID. Barcode was not correct, or there was something xylene on it. It read the barcode, but it could not link to the work list. It scanned the slide. Now you have 35 unknown slides sitting there, storage all wasted, and you don't know what to do with these slides. They're scanned and they're sitting there. Nobody knows what to do with them. No scanning without work list and ID integration. Very critical pain point that people suffer a lot. Check your system offsites at the weakest point and see if it's working fine. In the clinics, in remote clinics and everything like that, there's something timestamp mismatching. What happens is every computer has a timestamp. If they are not integrated together, sometimes the machine, the slides come and the result release or review happens, the time is not mismatching. You cannot audit the thing. So you need to make sure that it's something called NTP sync. Everything is synced through an NTP process. QCs, A lot of the scanners, they do QC, autofocus. If some portion is out of focus, they scan it, and or if the color is not consistent, it gives you a QC alert. You need to make sure that QC alerts are reviewed, corrected, fixed, and not just sitting in the backlog and creating problems. So again, we already talked about the AI. One of the things that I did not talk about is annotations. The future of digital pathology is in annotations. You know, I mentioned the two binary classification, parathyroid. The reason I was able to tell is because I annotated. It's a lot of work, but there are a huge limitation of annotated data. The pathologists don't have time to annotate data, but the way future is moving, because the market is increasing, companies are willing to pay pathologists the amount of salaries that they can to actually work on annotations. And that's why in low resource countries, a majority of the pathologists are getting involved in annotations. It's a huge industry. Please understand this. This is the future. Instead of scanning the slides automatically and figuring out patterns, it's a lot of work. It's too costly. If I can just annotate the area of interest and give it to the companies who work AI models, they are not pathologists. There are very few people who are AI and pathologists at the same time. Very few people. But majority of the times, the pathologists and AI have completely different things. The companies who are engineers who are working on it, they don't understand anything about the slides and histology. So people are combining and annotating. So you need to make sure that your annotation standards are perfect. And DICOM is the way to go for annotations. It actually creates a layer, another layer of metadata, which is annotations. You can easily call that data and it actually show you. And AI uses that same annotations. When you are looking for HER2 and ERPR, it actually annotates that. And the moment you click on it, it shows the annotated area, how it has annotated what as positive and negative. Okay? So please understand that annotation is very critical. And then this is just, I've already mentioned all these. This is the checklist of summary of everything that you need before you go. And then this is, now we are in the last step of lock the roadmap. So we need to understand that it requires a vision, it requires governance, it requires infrastructure, sizing. The infrastructure is you start with a pipe that is taking 10 Gbps network, but in future, you need to expand your bandwidth. You need to expand the size of the pipe to up to almost 40. When you start utilizing it more, the cases goes up. You need to expand. It should be flexible. It should be flexible to increase in size. Go for open standard. That's the best way to go. And then workflow integration, validate, and do the quality analysis, and make sure that you are AI friendly. So you can always jump into AI. And then these are just simple points that I have already stressed on. So I don't want to repeat that. And with that, I thank you. I appreciate it. Thanks so much. If there's any, I know I went a little bit longer than I was supposed to, but please, if there's anything that you want to ask, yes, go ahead, please.
Very exciting. What's it called? Only for the life. It's very helpful for the laboratory administration, location wise. So it saves huge amount of time for the lab to get slides. It's not easy to understand.
Yeah.
But compared to slides on a pathologist's desk, you get all the information case by case from your paper. So I looked at about 100 cases. How much time did I spend more using digitalized reporting? This is hardcore slides. But more than 3 to 5 times more amount of time that was required to finish
the digitalized cases. Who suffers? Yes. Perfect. We'll go for it. Excellent. Very, very, very beautiful question. One of the best questions ever asked. Literally, that pathologist requires more time to actually go through digitalized slides versus a glass slide. And as you mentioned, you looked at 100 slides on the glass, and then you looked at those 100 slides on a digital, on the digital side. Let me tell you one thing. When you start something new, it's definitely going to take you a lot more time. I'm just going to tell you right now, I used to use a Zeiss microscope, and I switched to Olympus in a high volume setting. Like I'm working at Mayo Clinic. You know, in America, we take off the stage. We don't have time for the stage movement. We take the slide, bare hand, slide out. I moved from Zeiss to Nikon. It just frustrated me. Change. It frustrated me. I was like, come on, which was a way better microscope than Zeiss that I was using. I said, throw this microscope out. I need my old microscope. Change is difficult. I totally understand that. Completely understand that. For that, I'm going to tell you something. How do you approach this problem? When you go digitize, you don't go digitize the entire hospital. Start with GI biopsies. Start with GI biopsies. We are digitized now. From tomorrow onwards, GI cases will never be published on a glass slide. Will be digitized only. The rest of the cases, you will receive the glass slides. Start small. Adopt. I have worked on digital systems. I'm telling you, at the end of the day, the pathologists using digitized slides will never go back to the glass slide. I've not won multiple examples. People, it took a lot of effort. Change is not that easy. I'm giving you an example from the microscope. I am in a very high throughput setting. I changed my microscope and I was frustrated. Literally, I called the guy, I say, come on, throw this microscope out and give me my old microscope. And he said, come on, I upgraded you. I said, forget about upgrade. I need my old microscope. So I totally understand. This is not easy. It's not difficult. We're completely changing everything. Take it by step process. Starts with one small thing that we are very comfortable with GI biopsies. Very comfortable. Very easy. Start with GI biopsies. Once you're comfortable, let's move to the cervical biopsies. Comfortable, let's do the hysterectomies. Exactly. I totally understand. So that's why I'm saying. Exactly. So you need to understand that you need to be part of the whole team system to bring digital pathology. Until your whole infrastructure is ready, do not get into the trap of bringing digital pathology. If the administration wants we are digital, and there is a lot of push from the AI, is a lot of hype right now, and everybody wants to show up, we become the first one to digital. Administration gets the point and pathologist suffers. No, I don't want to suffer. You bring the whole infrastructure and plumbing for me, I am the first one to get. And as a pathologist, I'm telling you, if I want to go a separate lecture on AI in pathology, that's a complete 2-hour lecture just separately. I have not touched that yet. So if I presented that to you, you will be so convinced that literally we have to move to these systems. Okay. So hopefully that answers your question. Actually, no, the cost is not too high. Radiology has already done it. The plumbing is already done. Is all how to kind of collaborate. You're thinking the cost of plumbing is very high? No, the plumbing is already done. The radiology is already using it. We just need to be integrated with that. The cost is not too high. It's literally a planned process of achieving it. Anybody else? I think we have, but I will be available anytime. Please reach out to me. And if you guys are interested, I'm available on LinkedIn. I do a lot of digital pathology, AI kind of things. If you're interested, do connect with me. Thank you so much. Appreciate it. Yeah. Yes. Yes. Thanks. We are requesting if you can get a group photo right now, and then we'll break for the coffee. Then we'll come back again.
Over there? Okay. So the presidency please, ladies can actually say, okay. Ladies, that way. Yes. You should. Do you like it? Yes. Wow. I'm not putting something in.
Good afternoon, everyone. Should we just start now? Hope it's working. It's working. Good afternoon. Good afternoon, everyone. Thank you so much, everyone, for coming back. And I would like to actually start our poster presentation. And our first session, I would like to welcome Dr. Akarana Hazarika from India. And I will like to pass the stage to her. She will be presenting a very interesting subject, metaplastic carcinomas of the breast. an old histotype with new diagnostic challenges, experience of an oncology referral center, an excellent, very nice topic. Thank you so much. Welcome. Thank you.
Hello, good morning. With the permission of the chairperson, I would like to start. I work in an oncology referral center, and we get to see a lot of cases of breast carcinoma. So I have put together a case series of metaplastic carcinoma of breast, and I shall also be discussing the diagnostic challenges as I go through my slides. So the most common carcinomas that we get are actually adenocarcinomas only, but a very few subset of cases usually show non-glandular morphology and growth pattern, which we subject to call it as metaplasia. And the most common metaplastic change that occurs is the apocrine change. But we also get to see squamous, chondroid, osseous, spindle cell, all such changes. And these cases can present with monophasic or biphasic components. So the WHO classification has introduced these 5 subtypes: low-grade adenosquamous carcinoma, fibromatosis like metaplastic carcinoma, squamous cell carcinoma, spindle cell carcinoma, and metaplastic carcinoma with mesenchymal differentiation. All these subtypes tend to show morphological mimics and intratumoral heterogeneity, which is why the diagnosis and categorization is both challenging and important. So keeping this aim in mind, we have included 4 cases in our case series, and we have included only the metaplastic carcinomas and excluded other histological subtypes of breast carcinoma. So this is how our flow pretty much looks like. So the oncologists refer their cases and send the core needle biopsies to us, and then after histopathology and IHC, we give a diagnosis on the core needle biopsy, which is then presented before a tumor board. Then, after having received the surgically resected specimens, we go through a basic grossing protocol where we submit the tumor sections along with the sections for margins, base, skin, and the lymph nodes. And the reporting is done as per universal norms. So the 14 cases that we got showed mostly patients of the elderly age group, along with very large size lesions with complex echogenic masses, speculated margins. So presenting for a few cases, the first case is that of a 49-year-old female. The breast lump core needle biopsy showed tumor cells with mostly squamoid morphology along with keratinous areas. This was established by P40 IHC. ER/PR, as we know, are almost negative in all the cases of metaplastic carcinoma. So before signing it off as a squamous cell carcinoma or pure squamous cell type metaplastic carcinoma, we had to go through extensive elimination of the primary SCCs elsewhere in the body. Also, one more important thing to rule out is adenosquamous carcinoma, which has been included by the WHO, and especially the low-grade subtype. So extensive sampling for glandular component is necessary in the resection specimens. The next case that I want to show is a mastectomy specimen where we can see the invasive ductal carcinoma component showing very pleomorphic cells with plenty of chondroid matrix in the background. In these kind of cases, gross and microscopic findings go hand in hand. If we do not find a DCIS or an invasive ductal carcinoma component, then the differentiation between a metaplastic carcinoma and a sarcoma becomes very difficult. So immunoreactivity for both CK and S100 is equally important. So the next case is that of a core needle biopsy from a 56-year-old female. So spindle cell lesions of breast are a whole new conundrum as a whole. So here we can see haphazardly arranged fascicles of spindle cells. GATA3, as we know, is of very little importance in metaplastic carcinomas. And these spindle cells were positive for SMA. But the pan-CK reactivity in the small biopsy was actually missed by us, and the mastectomy specimen came, and after that, when we saw spindle cell, when we saw it to be a spindle cell lesion, we had to rule out a lot of differential diagnosis, starting from fibromatosis to phylloids. So then we put a pan-CK, which came out positive, and we had to label it as a low-grade fibromatosis-like pattern of metaplastic carcinoma. Identification of this subtype is important because it does not have a rapidly aggressive morphology. One more case, we had similar presentation, and that in that the core needle biopsy went as phylloids tumor versus metaplastic carcinoma, but in the post-op specimen only we could see stromal hypocellularity with overgrowth with presence of osseous foci, and had to be given as phylloids tumor. So the challenges in core needle biopsy are one of the most commonly encountered caveats in the diagnosis of metaplastic carcinoma, and the extent of changes usually range from very small microscopic foci to complete replacement of the glandular tissue. And so these foci tend to be easily overlooked or ignored. So these are some of the review of literatures that I have gone through. So this is an old histotype. I have called it an old histotype because we have seen studies starting from 2002 up till recent times. So the recent molecular advances that have been included are the PIK3CA mutations and TERT promoter mutations, along with other targetable mutations such as EGFR. So to conclude, the identification of low-risk histology is particularly important because the subtypes if carcinoma with fibromatosis-like pattern and the low-grade adenosquamous carcinoma show indolent behavior. But if we encounter more number of morphology, especially mixed types, these show a worse outcome. So the recent molecular studies and genetic profiles and whatever studies that we have done, so if we publish those studies, hopefully there will be more literature to refer to and more diagnostic and prognostic implications to refer to in the coming future. So these are my references. This is the institute where I work in, and this was the last breast cancer awareness camp that we had done. Thank you.
Any questions and opinions, please? Yes. Do you have any experience with metrics only using
Matrix producing, we haven't got any. Thankfully, I would say thankfully only because we got to see invasive ductal carcinoma in the case that I have shown today. But there was one case particularly where where we were confused even with mucinous carcinoma also, whether it was a mucinous carcinoma, matrix producing carcinoma, because we had to do extensive sampling to find one DCIS focus. So after extensive grossing, we could find few DCIS foci, and then we labeled it as matrix producing metaplastic carcinoma. But the differential diagnosis of mucinous carcinoma also came into play, and we also had to rule out a sarcoma. So that was quite difficult, but only matrix producing without any DCIS foci, I haven't gone through till now.
2 weeks ago? So more. And then the whole system assessment page is lasted. And it just quite beautifully shows that hopefully 100% match using so with no evidence to be here, in no IPC, any others. Very unique.
Thank you, sir, for sharing your experience. Actually, we get to see this a lot. Even spindle cell lesions, I have shown one today, but ultimately we get a relief when we get the resection specimen, because then we can submit as number of sections as we want, and then we can actually arrive at a good diagnosis. Otherwise, most of our cases also on core needle biopsies, we have to give it as a differential diagnosis rather than giving it a specific diagnosis. And then we have to call up the clinician on a hurry. Okay. Okay.
Can you, very nice. I just wanted to ask you about needle biopsy
Yes.
and calling it a straightforward metaplastic versus giving a differential.
Yes.
What do you guys recommend in that sense? Because you have looked at many cases. What was the usual process of it? Because in a needle biopsy, sometimes it's kind of a little bit
Yes, very,
not sure,
very
very
difficult, very
kind of come
tricky.
to the conclusion
Yes.
quickly, yeah.
Most of the cases actually, I think around 8 cases went as invasive ductal carcinoma only. I'll be very frank in that. And the first case that I had shown squamous type, that one we were lucky enough to see those squamoid cells and the keratin. I have shown that picture from that core needle biopsy itself. So we ran a P40 and we could give it out as a pure squamous type metaplastic carcinoma. But out of the 14 cases, only very few cases that I could give my hold on metaplastic carcinoma on core needle biopsy. Rest, we had to correlate with the resection specimen. And it is safe to correlate also rather than calling it one on the biopsy.
Thank you so much. Appreciate that. Thanks a
Thank
lot.
you so much. Thank
Yeah,
you.
I can take.
Yes, yes. Okay. I think I'll close this one.
Don't worry.
It's okay. No problem. Okay.
No. Thank you so much. Now I would like to move forward to the next poster presentation by Dr. Sukrob Tashmatov from Uzbekistan. Very nice to be here. And I'm passing the stage to deliver an excellent presentation on molecular and immunohistochemical profiling of pediatric brain tumors in Uzbekistan. Thank you so much. Thank you.
Assalamu alaikum. It's my pleasure to show you our preliminary examination results of about of molecular and immunohistochemical profiling of pediatric brain tumors in Uzbekistan, and this is a preliminary investigation into the implementation of molecular and immunohistochemical diagnostics for pediatric tumors in brain tumors in Uzbekistan. And I'm Dr. Sukhrov Tashmatov, working at the National Children's Medical Center Pathology Department. And our center has 218 beds. It has 12 departments and 10 additional service departments. In April 2024, MCMC became the first state medical organization in Uzbekistan to receive international JCI certification, and we are the only a specialized children's center in the world that has passed this accreditation. Abstract. What we did, we started 72 brain tumor samples from children aged 2 to 17 years in Uzbekistan in our center. And we used basic microscopic routine analysis by histology and spatial stains by immunohistochemistry and some genetic tests. And we test for important markers P53, NEU-N, GFAP, and mutation in IDH1 and H3K27M genes. And what we found, high levels of P53 and the H3K27M mutation were linked to a worse outcome for patients. And using these biomarker tests is very important for better diagnosis and personalized treatment for children with brain tumors in Uzbekistan. And relevance of study, brain tumors are the most common solid malignancies in children, representing a major cause of cancer-related deaths globally. In Uzbekistan, pediatric neuro-oncology diagnosis primarily rely on conventional histological analysis, and which is often insufficient for precise tumor subtyping or prognostication. The global shift towards molecular classification, especially in gliomas and embryonal tumors, underscores the need for national adaptation. Mutation like H3K27M in diffuse midline gliomas or IDH1 in gliomas significantly influence therapeutic strategies and survival outcomes. This study provides the first institutional data on the use of these markers in a pediatric population in Uzbekistan, aiming to integrate international classification standards into local diagnostic workflows. The objectives are to study the importance of K protein and genetic markers in children's brain tumors and to understand how these tests can help to doctors in Uzbekistan diagnose better and plan treatment. Material and methods. Specimen collection is 72 pediatric tumors, simplest and were obtained from surgeries performed between 2020 and 2023. And we do standard hematoxylin staining, and then we do immunohistochemistry staining, and also we do genetic analysis by PCR, and finally we do statistical analysis. Clinical relevance. As you know, specimen collection is 72 pediatric tumors, and hematoxylin plus immunohistochemistry helps to accurately identify the tumor type and its behavior. And genetic test by PCR finds a specific genetic mutation to guide targeted treatment options. Classification by WHO and statistical analysis by KM uses international standards for diagnosis and to understand patient survival. Comprehensive testing, combining all methods gives the most complete picture for each patient, and high diagnostic value leads to more genetic mutation that affect prognosis. And our results, gliomas were the most common, more than 50 to 52%, and embryonal tumors were next, 26.4%, and ependymal tumors were 13.9%. P53 high levels were found in 34.7% of aggressive gliomas and medulloblastomas. Also, H3K27M mutation was found in 9.7% of tumors, and Most were in the thalamus and pons areas of the brain. IDH mutation was found in 5.6% of cases. All were in a type of glioma like supratentorial diffuse astrocytomas. And GFAP was positive in more than 19% of glial tumors. And this protein was active in neuronal tumors and statistically high P53 was significantly linked to high tumor grade. And patients with H3K27M mutation had much shorter survival. Conclusion: this preliminary study confirms the feasibility and clinical utility of molecular and immunochemical profiling in pediatric brain tumors in Uzbekistan. The detection of P53, H3K27M, and IDH1 mutations contributes to more accurate tumor classification and prognostication. The results supports the integration of biomarker-based diagnostics into clinical practice, paving the way for risk-adapted therapeutic strategies. Expansion of such research on larger multi-center cohorts is essential to establish national protocols aligned with global neuro-oncological standards. And we have some goals for next year, and they are create a national registry for brain tumors in Uzbekistan and also establish a central agent molecular diagnostics consortium to work with other countries in our region. And of course, this will be help us improve care of children. Thank you. Thank you.
Thank you so much. That was a very hardworking and very good presentation. Any questions from the audience would like to ask? I would like to ask is that how do you do the molecular testing?
By PCR from paraffin.
Do you guys have access for NGS testing as well?
Yes, yes.
Okay. Are you utilizing the NGS testing?
Yes, yes, yes. We have another genetic laboratories.
Who perform the NGS?
Yes, yes.
Wonderful.
We just sent.
IDH mutation reduction.
Yes.
Thank you so much. That was excellent.
Thank you so much. And this is just preliminary examination.
Preliminary data
Yes.
for the
Maybe next year we will show you.
full.
Yes, full.
That's excellent. Thank you so much. Very nice. I'm not connected with this. With that, we will move to our third poster presentation. And that the next poster presentation is by Ms. Dr. Voropeva Yana from Russia. And she will be presenting on cytological diagnosis of follicular thyroid lesions. Welcome, please. Thank you.
What start the presentation?
Yes, you can start now.
Uh,
Let me help you just.
help, please.
Yeah. Okay, move. It's okay.
Good afternoon, dear colleagues and dear teachers. I'm so happy to be here today, and I want to say a lot of things for this opportunity. I would like to tell cytopathology diagnosis of follicular thyroid lesions. According to the Russian Cancer Registry in 2023, a total of 674,587 cases of newly diagnosed malignant neoplasms were registered in the country. Of the total number of newly diagnosed malignant neoplasms, 3,037 cases were diagnosed in men, and 13,788 cases were diagnosed in women. The mortality rate was 328 cases. The aim of this study was to evaluate the morphological filter's contribution to diagnostic errors and propose measures for improvement. From January to December 2024, 5,124 5-needle aspiration biopsies of thyroid nodules were performed at the Loginov Moscow Clinical Scientific Center. Of these, 388 patients underwent surgery, with an average age of 55 years. Cytological results identified benign lesion in 6% cases, follicular tumors in 22%, suspicion of malignancy in 11%, and malignant lesions in 59%. All cases underwent cytohistological correlation with an overall diagnostic accuracy of 90%. False positive results included 6 cases of papillary cancer and 17 cases of follicular tumors due to follicular nodular lesions and nodular hyperplasia of the thyroid gland. False negative results were observed in 7 cases, including 4 cases of follicular tumors. I would like to present several clinical cases that have been identified as discrepancies in our practice. Female, 72 years old, with an isechoic node in the right lobe of the thyroid gland and normal calcitonin levels. Here you can see cells with rounded nuclei, abundant cytoplasm, no colloid, and rounded bionuclei. Magnification 100 and 400. With some cells at 1000 magnification. According to the cytopathologist report on the suspicion of follicular variant of papillary cancer. According to the international classification, the test 5. After an immunohistological study, our colleagues concluded that it was trabecular variant of follicular adenoma. The next clinical case, female, 47 years old, with an hypoechoic node on the right lobe of the thyroid gland and normal calcitonin levels. Here you can see clustered follicular structures and stromal matter with predominance of nuclear elements. Magnification 100 and 400. And 1000 magnification. According to the cytopathologist report, cytological picture of follicular tumor. According to the Bethesda classification, Bethesda 4. However, the histological report indicated an invasive follicular variant of papillary carcinoma. This case is very difficult to diagnose cytologically, as we only see follicular structures in the cytological material, and there is no way to assess the invasion. Our data demonstrate that follicular thyroid lesions pose significant diagnostic challenges for cytopathologists. Therefore, additional diagnostic methods such as molecular genetic testing should be introduced. This is our friendly team. Thank you for your attention.
Anybody from the audience have any questions? I would like to ask, you regularly use Bethesda system for reporting? Regularly use Bethesda. Do you have by chance any exposure to molecular testing of follicular and PTC lesions? Separate, but do you regularly, sometimes in difficult cases, send cases for molecular testing, or no? Usually no. Thank you so much. Appreciate it.
We after operation.
Okay, I got it. Thank you so much. Appreciate it. Thank you so much. So we move to our next poster presentation by Dr. Maria Kotova. She's also from Russia, and she will be presenting on prevalence of high-risk HPV infection in women with the normal cytology. Very interesting topic. Very nice.
Hello, dear colleague. I'm really happy to be here today, and I would like to say a lot of thanks for this opportunity. I'm a cytopathologist from Moscow Clinical Scientific Center. I work with Yana in one laboratory. And today I would like to share you with our experience, our first steps of screening system, cervical cancer screening. And I would like to talk about prevalence of high-risk HPV infection in women with normal cytology. According to global can to incidence and mortality of cervical cancer in 2022 was seventh place among all malignant neoplasms, fourth place among neoplasms in women, and second place among malignant tumors of reproductive system in women. The incidence and mortality of cervical cancer in Russia increased too. And according to the global can reports in 2020, 2040, situation might be like on my picture. But all of us know about World Health Organization global strategy for the elimination of cervical cancer in the world. 90% of girls fully vaccinated with HPV vaccine by 15 years of age. 70% of women screened using a high performance test by 35 years of age, and again by 45 years of age. 90% of women identified with cervical disease are treated. 90% of women with precancer are treated, and 90% of women with invasive cancer managed. We know two types of screening: organized population mass systematic, it's of course it's better variant, and opportunistic spontaneous disorganized. And in Russia we have opportunistic kind of screening globally in all countries. And we know a few of cervical cancer screening strategies. First of all, it's only cytological examination, HPV testing, and later cytological examination, co-testing, HPV test plus cytological examination, and HPV testing, test and immunocytochemical examination, P16, P67 co-testing. We know that cytological examination doesn't have a good level sensitivity and specificity level. And if we use HPV testing and cytological examination, it's better variant because sensitivity up to 98.1% and specificity up to 95.1%. And in our center, we use this variant of for our examination, co-testing. Material and methods. Cervical smears were obtained with cervical brush and cervical brush combi, cervical brushes. The exam were performed in 876 female from 20 to 70 years old. They were placed into transport liquid BD through path, and the preparation was performed by BD through path method. The PCR examination to identify high-risk HPV was performed on COBAS system. And here you can see that the peaks of detected HPV they occur at the age of 20 years. And this group of patients in whom the virus is often eliminated. And however, there is also a peak at 45, when elimination of virus is not so likely. And this is a group for a risk of malignancy. It is this group that should be taken into account in screening programs despite negative cytology. And in the conclusion, we detected the peaks of cervical high-risk HPV infection among women in Moscow, and we should pay attention to women with normal cytology at their early 40s. Moreover, HPV testing should be performed for this group of women in screening programs. Here you can see our colleague who helped us with this work and different studies. Thank you for your attention.
Thank you. Anyone of the any questions I'd like to ask? Can I ask you about the HPV high risk type that was more common? For the 16-18?
16-18 and sorry, thank you for your question. 16-18 and 33 and something 11 types of high risk. Yeah.
What is the prevalence of vaccination?
We don't have vaccination. Yeah, we don't have a vaccination program in Russia now. I know that it's like a study in some cares clinic. We have this program, but not in all Russia.
Very interesting. I would like to basically mention that, in the vaccinated people, 16, 18 goes down because of the vaccination. And then the 33 starts coming up very, somehow vaccinated people tend to have a lot of 33 and 35 and not that much 16, 18. And you seems like the population is 16, 18 is the most common one. And then there is some 33 as well.
Sorry, I don't know, because we are only cytopathology, and we have different department, like Yana said, which have this molecular testing and HPV testing, PCR laboratory. It's a little bit different department, because I can only it will be only my meaning about it, not professionally.
Thanks.
Good.
Thank you. Very nice invitation. Yeah.
It's not my, it's Yana's.
Oh, you know what? Maybe we should change it.
How about yours?
Okay, sit down. No, no, very nice. Did I give you the wrong one? No, it's fine. So I had double copies for you. Thank you. Thanks so much. Appreciate it. Thank you. Very exciting. Yes, thank you. Okay, and we are at the last post presentation, and Dr. Abdulaziz Al-Nouri, I would like to introduce from Saudi Arabia, and he's presenting a very interesting topic, which is very close to me because of the AI and neurovascular mapping of assiduous labor. And welcome.
Thank you very much. I will
Just need to close it.
okay. I have updated one.
Sure, you can do this one.
No, keep.
You mean looking good?
Okay, wait, so don't need it. Just a check. First one. Yeah, just. Hello, everyone. Today, inshallah, my name is Dr. Abdulaziz Al-Ameri. I'm an assistant professor in King Saud University, clinical anatomist, and I will talk about the intersection between science and the clinical practice. I will try also to shed some light on the digital pathology and how exactly we can build a bridge between science and the clinical practice and what we actually can do together. my work intersects with orthopedic surgery, rheumatology, and pathology at the same time. So today I will present a segment of my project, and we will talk about the acetabular labrum. So the acetabular labrum is a soft tissue, is a fibrocartilaginous soft tissue. It's, if you think of the hip joint and the rim of the acetabulum, you will find a very circular soft tissue which encircles the acetabulum, and this plays a role more or less like the knee meniscus. So one of the main issues that with the acetabular labrum tear, we don't exactly know what is the neurovascularity, which influences heavily the healing and the surgical approaches for either reattachment or resection or multiple treatment strategies. At the same time, we don't have a clear idea of the mapping, if we think of the mapping across the clock face of the hip joint, saying anterior, superior, inferior, or posterior, and we don't know about the neurovascularity at the cross-sectional level. And the question is, would that cross-sectional level affect if we already know the clock face neurovascularity? So I will specifically present neurovascularity and its relation to labral tear. So our workflow is a little bit big, but I will take the innervation from the immunohistochemical staining that we did with P75 and smooth muscle actin for vascularity. Then I will show something related to our classification of labral tear and the question of, is the area of the labrum at the cross-sectional level be an influence to either tear or vascularity and innervation? So what we did is, first we segment the acetabulum to 8 regions that we take from the designated regional sides, so superior, anterior, inferior, and posterior. Then we go through that through sectioning, then staining, and we will present how this can give us some ideas. So this is one of the SAFO stains that we did of the labrum. So if you can see the labrum at the cross-sectional level, this is the labrum, this is the capsule, and this is the articular cartilage, and this is the labral attachment to the bone, and this is the subchondral bone. So this is the cross-sectional level, and the question is, what is the labral tear? How would that tear be affected? And where exactly can we see the innervation and vascularity? We know something else from similar fibrocartilaginous tissues, such as the knee meniscus, that there is something called functional adaptation to mechanical load. More mechanical load means more fibrocartilage, more compact substance of fibrocartilage, less ability for vascularity and innervation to penetrate. From the knee meniscus, if we want to draw some parallel, we know that there is 3 zones. There is a vascularized zone, there is a region in between, which is not so vascularized, not so innervated. Then we have a dead zone. We have avascularized and not innervated zone. And this, in the knee meniscus, this has affected already the surgical repair, where studies has shown that if we repair at the vascularized zone, we will see more potential for healing, and the tissue might regain some of its property. We don't know if this is the case in the acetabular labrum. So let's look to the functional adaptation of the labrum. And to do that, we should segment the labrum in a way that even if the shape of the labrum is different, our segmentation is consistent. This is very important in segmentation. So we extracted the labral area and we did something called the zonal analysis. So we have an inner zone, which is near to the articular side, and the outer zone near to the capsule. Then we did some quantification. We did the density of P75 and actin for blood vessels and innervation. And with the previous zonal analysis, we were able to do a zonal mapping at the cross-sectional level, which tells us where exactly can we see vascular blood vessels and nerves. And this is our criteria. Then we build a criteria actually for what constitutes blood vessel and nerve. This is very important as well. And through that, we went to the nerves and we classified the nerves to mechanoreceptors, free nerve endings. And this will also gives us some hint of what we are exactly looking at. And whether the sensory innervation is perivascular or non-perivascular, and this is related to angiogenesis and how this make blood vessels an indication of innervation. So if we look across the clock phase, the distribution of blood vessels and innervation is same. Raising again the question, we have a high prevalence of tears at the superior and anterior region. Would that mean that, okay, it's equally vascularized, equally innervated, nothing will happen, it's a matter of a surgical approach? But if we go to the zonal level, we will see that this region near to the articular side is nearly avascularized, just like the knee meniscus. And we have a significant outer side vascularization and innervation near to the capsule. So again, raising the other question, where would you find the tear? But going in like more in depth, this is in general within all over the samples. If we segment the samples based on the anatomical quadrant, we will see the same results. That the outer zone near to the capsule is highly vascularized, highly innervated across all quadrants. This is our criteria for labral tear. We implemented the criteria. Then we ask this question. This is, it's too big here, sorry about it. But this is the labral tear as we can see it from the eosin properties, the fluorescent eosin properties. In conclusion, with labral tears, our results is very, very similar to the literature and tells us something else, that the localization of labral tear is at the avascularized and not innervated zone. So what exactly should we do with this information? We have an anatomical quadrant level, we have a cross-sectional level. This is how innervation and vascularization goes from the outer side to the inner side. And tear is localized at this region and more or less at the superior to the anterior side. So what we are saying is that this can influence the way that we see repair, the way that we approach repair, and maybe the surgical reattachment strategies could be different, just like what happened with the knee meniscus, but for the acetabular labrum. So in conclusion, neurovascular supply was examined using immunohistochemical labeling across zones and anatomical quadrants. At the quadrant level, it was consistent. At the zonal level, showed a very great disparity between the inner and outer zones, which also correlated with the localization of labral tear. And this, again, scientific research at the clinical side could be really informative for clinicians to improve new approaches. Thank you very much.
Thank you so much. That was very interesting because we at the district pathologists, we get the acetabular head all the time.
Yeah.
They just cut it off, and we send it to the lab, and we look at it sometimes do the cross sections just to make sure there's no tumor there. But we never looked at vascularity and the regeneration and everything like that. It's very powerful, very interesting. Any questions from the audience? So can you tell me from the basic I understand, if we have this piece of information that the new vascularity is a little bit more on this side, what are you going to tell the surgeons now? What can we learn from this that will help surgeons to actually change their process?
In labrum specific, the practice went from resection, complete resection of the labrum, then preservation, then multiple types of preservation. We can say that we could look for an approach of reattachment. We can anticipate prognosis based on the regional tears and where they might be. And we can also anticipate that based on gender, based on sex, male, female, and the health in general.
Do you think, is there anything we can do from this information that the lab can actually learn from it and do a process to suggest to the surgeons? Right now, it's a very useful piece of information, very helpful. But how can I clinically convert it into an action that can help the patient? That's my main question right now.
Honestly, there should be a collaboration.
Collaboration, exactly.
This is the surgical side, the diagnosis side, and the radiology as well. This is like a complete team that should approach the matter. Then there should be a protocol for it.
Thank you so much. That was very interesting.
Thank you very much.
Right. Yes. Okay, with that, thank you so much, everyone. This was our last presentation for the day, the second day. Thank you so much for coming. And with this, we conclude our digital pathology and cancer conference. I extend my thanks and gratitude to everybody of speakers and delegates and partners who for their invaluable contribution and over the sessions and explore the groundbreaking advancements that you acknowledge and build connections that will continue to inspire progress in cancer research and digital pathology. Let us carry forward the insights that we gained from here into our work and collaboration in communities, wishing all of you success, and we look forward to the future events. Thank you so much, everyone. And I think we will take a picture right now, and then we will proceed for the lunch. Thanks, everyone. Okay, we will actually have the delegate certificates distribution will happen after the group picture, right? Yeah. After the group picture. Thank you so much. It's just can we just come